We are ready to start the next session, which is going to be a physiology session by Dr. Kamal Jindal. Well, let me ask you all beautiful people, wonderful people out there, are you ready? Are you ready? Yes, I know, and I hope all of you are ready to get along in this learning roller coaster, which is called the DAMS Visual Treats, DAMS DVT 2023. We are going very steadily in the learning process, and one beautiful thing about learning is that no one can take it away from you. Yes, and our teachers, our faculties, our esteemed tutors are putting in a lot of effort to make it worthwhile. Next session is physiology, and I am proud to welcome Dr. Kamal Jindal. Dr. Kamal Jindal has done his MBBS from UCMS, New Delhi, and has done MD Physiology from Maulana Azad Medical College, New Delhi. He's got a vast experience of around 14 years, which is long, yes. And he has really loved to teach in DAMS Medicos. The moments that he has cherished, which are fresh in his memory, is the love and adulation that he got from the students when he traveled far and wide in 2023 at different places, touching the lives of many students by his teaching skills. I welcome Dr. Kamal Jindal, and he will be taking physiology.
Yes, very good evening everyone. So we are here to do the DVT for physiology. I am Dr. Kamal Jindal. Yes, good evening everyone. Good evening Ishan, Abhishek, Ashish. Yes, Harshil. Very good evening. Yes, hello Akshay. So we'll be starting with the yes everyone. Once again, good evening. Yes, I hope you are enjoying the session. So pleasant evening to you all. And yes, so let's begin with the first thing in general physiology and basic concepts, distribution of total body water, right? Distribution, volume is low. Okay, we'll just get it rectified. Yes, good evening. So total body water, remember total body water is 60% of the body weight, right? 60, yes, we are increasing the volume, don't worry. 60% of the body weight. So if we have a male whose weight is 70 kgs, then the total body water, yes, we are, yes, Betyan Das, very good evening. Yes, we are just channelizing the audio, don't worry. Yes, we are just doing the audio. Don't worry, we are getting the audio done. Yes, so if the total body water is 70 kg, right, so total body water is 60% of 70 kg, that means it would be near about 42 liters, right? Yes, absolutely correct. So ICF is, remember, 2/3 of the 60%, it is 2/3 of the 60%, that would be 40%, right? 40%. And ECF is the 1/3 of 60%, that is 20%, right? So remember, we used to call it as rule of 60-40-20 distribution of body fluids. Okay, Malbi Viswas, it will be taken care, don't worry. Then we are dividing ECF into broadly 3 compartments, which is 1/4. So what is 1/4? 1/4 is the plasma volume, right? 1/4 is the plasma volume. Yes, the remaining 3/4 is the interstitial fluid volume, which is 15%. So 5% is the plasma volume. Yes, that's correct. And this is the 15% interstitial fluid volume. And remember, we have another compartment which is only 1 to 1.5%. That is transcellular fluid, right? This is transcellular fluid. What is transcellular fluid? The transcellular fluid is the fluid which, the transcellular fluid is the fluid contained within the epithelial lined cavities, right? Such as your pleural fluid, pericardial fluid, synovial fluid, right? All those fluids are transcellular fluid. Remember which dyes we use to measure total body water? Yes, the mnemonic is that total body water, deuterium oxide, aminopyrene, tritium oxide, right? Which dyes do I use to measure the extracellular fluid volume? Sucrose, inulin, mannitol, radioactive sodium, right? And which dyes I use to measure the plasma volume, radioiodine labeled albumin, and the Evans blue, right? Let's move on to the cell membrane. So cell membrane, I have the fluid mosaic model, which we all know. So basically, what is the thickness of the cell membrane? The thickness of the cell membrane is 7.5 nanometer or 75 angstrom, right? 7.5 nanometer or 75 angstrom. ये सही नहीं है, ये नीचे है बहुत, लिखने में दिक्कत हो रही है. Abhishek R. Singhvi, I have already told the dyes in the class and everything, right? So yes, I can't write the dyes. Yes. No, you already know the dyes. Yes. The total body water. Okay. The total body water is measured with the help of deuterium oxide D2O, aminopyrine, and tritium oxide. Right, so tritium oxide, this is total body water. And for extracellular fluid volume, we have, you have all been taught the dyes. Yes, so this is DAT, DAT. The extracellular fluid volume is SIMAN, sucrose, inulin, mannitol, and radioactive sodium. Sucrose, inulin, mannitol, and yes, I'm telling you the mnemonic, just listen patiently, mannitol and radioactive sodium. Radioactive sodium. Right, radioactive sodium is SIMAN, yes, Na is SIMAN, absolutely correct. And finally, for plasma volume, we use radioiodine labeled serum albumin. For plasma volume, we use radioiodine labeled serum albumin. Radioiodine labeled serum albumin, right? It is radioiodine labeled serum albumin. Let's move on to the cell membrane. So what is the normal thickness of the cell membrane? Normal, yes, Evans blue is also there, but I've just written the important one. So you already know the dyes, right? Let's not waste the time. So for plasma volume, radioiodine labeled serum albumin and Evans blue. Yes, best is radioiodine labeled albumin, right? And here we are using commonly inulin. Inulin is most commonly used and radioiodine labeled serum albumin is most commonly used, right? Here aminopyrine is the most accurate. Okay, let's move on to cell membrane. So normal thickness of the cell membrane, as I was telling you, is yes, Tanmay, don't worry, I will do that, don't worry. Yes, I'm going to ignore the chat and not going to, something, we are not going to waste time again in the dyes. That is going to take a lot of time otherwise. Yes, so thickness of the cell membrane is 7.5 nanometer. Yes, PS. यार ये माइक सही नहीं है, गिर रहा है. ठीक नहीं है यार, ये ठीक नहीं है. Thickness of the cell membrane is, yes sir, I'll do fast, don't worry, just a mixture. Yes, thickness of the cell membrane is 7.5 nanometer or 75 angstrom. The lipid protein ratio is 1:1, right? It is 1:1. So generally we say that the by weight the proteins are 52% and the lipids are 48%, right? So the ratio is by weight 1:1. The proteins, as you know, can function as integral proteins or the peripheral proteins, which can further function as the channel proteins, ions, right? Ion channels, carrier proteins, enzymes. But the peripheral proteins are always functioning as enzymes, right? Always enzymes. Moving on to the intercellular junctions, we have the tight junctions, which is made up of the proteins who are the proteins which make up the tight junctions or the zonal occludence. What is zonal occludence? It is an apical membrane-like ridge where adjacent ridges are opposed, tightly. And as we say, the zonal occludence form tight junctions and the leaky tight junction. The tight junction, as it is clearly shown in the figure, are made up of 3 molecular proteins: occludins, claudins, and JAMs. What is JAMs? Junctional adhesion molecules, right? Junctional adhesion molecules. So where do I commonly see the tight junctions? Yes, claudin is Pramod, right? We commonly see the tight junctions in the luminal side. We commonly see the tight junction in the luminal side on the proximal convoluted tubule, DCT, and collecting duct, right? We also see the tight junctions on the luminal side in the intestinal epithelial cells. Intestinal epithelial cells, right? Intestinal epithelial cells. So tight junctions, luminal side PCT, DCT, collecting duct, intestinal epithelial cells, we are seeing the tight junctions. Remember, we also see in the PCT the junctions known as leaky tight junctions. Leaky tight junctions are seen in the PCT, and the transport which occurs through leaky tight junction is known as paracellular transport, right? Paracellular transport. Paracellular transport. Absolutely correct. Ranjim Garbai Jethwa, that's correct. And the another place where I see the tight junction, very important location, which I was coming to, the box, which is blood-brain barrier. Blood-brain barrier. Nisanksha, third spacing is basically when the fluid leaks out of the capillaries into the interstitial spaces. That is known as third spacing. That is an obsolete concept. We are not using it anymore, right? Moving on to blood-brain barrier, is formed by the tight junction between endothelial cells of cerebral capillaries, that's clearly mentioned in the figure. And the parts of the brain which are outside the blood-brain barrier are known as circumventricular organs, which is remembered with the help of a mnemonic SOAP, where S stands for subfornical organ, where S stands for subfornical organ, subfornical organ, blood-brain barrier, triple breeze, blood-brain barrier, Mohammed Shehbaz. Subfornical organ, O stands for OVLT, organum vasculosum of lamina terminalis. OVLT, organum vasculosum of lamina terminalis. A stands for area postrema. Area postrema. Organum vasculosum of lamina terminalis, right? So don't please ask me to write down the full form of OVLT, right? That should be known to you all. P is pineal gland. Yes, that's correct. Pineal gland, that is for P, right? Pineal gland and posterior pituitary. Moving on to the parts of the brain which are outside the blood-brain barrier is known as the circumventricular organs. So the mnemonic is SOAP. If you want to add median eminence, we can also say it is MySOAP. But in physiology, generally they mention as SOAP, right? Moving on to the other one, now we have the then adherence junction. Adherence junction, as we can see from the figure, again located behind the tight junction. CTZ is not the part of the circumventricular organ, Abhinav Garg. That is in the floor of the fourth ventricle. So moving on to adherence junction, they are mainly made up of microfilaments. The desmosomes are made up of intermediate filaments. Intermediate filaments, and these are microfilaments, right? These are made up of microfilaments. Let's move on to the gap junctions. So example of tight junction I have told you. Yes, vomiting center is the area postrema that we will discuss in GIT. Moving on to the gap junctions. Gap junctions are made up of the proteins known as connexons. They are made up of proteins known as connexons, right? And each connexon is made up of 6 connexins. Each connexon is made up of 6 connexins, right? 6 connexins. And connexins form the junctions known as electrical synapses. That's correct, electrical synapses. You also know a disease, X-linked disease, which occurs due to mutation of connexon. The disease which occurs due to mutation of connexon, Charcot-Marie tooth disease. Right, Charcot-Marie tooth disease. It's a demyelinating disorder which occurs due to mutation of connexon, right? Then basically we say that in the connexon, the intercellular distance, normal intercellular distance is 25 nanometer, but at the gap junction it reduces to 2 to 4 nanometer, right? So normal intercellular distance is around 25 nanometer, but at the gap junction it reduces to 2 to 4 nanometer, right? Where are the gap junctions present? So most of you have already given me the right answer. It is present in the cardiac muscle. It is present in the cardiac muscle. It is present in the single unit smooth muscle, right? Single unit smooth muscle is present where? Walls of the hollow viscera. Yes, pore size is 0.8 to 0.1.4. Absolutely correct. Karan Parekh. So cardiac muscle, single unit smooth muscle, also seen in retina, right? So yes, that's correct. So let's move on to comparison between ECF and ICF. Another very important one. So osmolality of the ECF and ICF is same. Remember, otherwise the fluid will move. So this is 290 milliosmol per liter. This is also 290 milliosmol per liter. Nisanksha, heart is both mechanical and electrical syncytium. Major cation here is sodium, here it is potassium, right? Here it is sodium and potassium. The osmotically most active particles, sodium, single unit smooth muscle. Shreya, it is SMA smooth muscle. Yes, major cation, sodium again. Here it is major cation, potassium. Major anion, chloride more than bicarbonate. And here major anion, phosphates. The pH is 7.4. This is 7.1, right? 7.1. Then we have the most abundant buffer and the most important buffer. Remember, here the answer is same. It is bicarbonate and bicarbonate. Most abundant buffer is my phosphates. But the most important buffers are the proteins. Why proteins? Because as we do in class, the pK of the proteins is close to intracellular pH, right? That is the reason pK of the proteins is close to intracellular pH. The pKa is close to, the pK of the proteins is close to intracellular pH, right? Yes, 7.1 ICF, absolutely correct, right? So where are the proteins more? ICF. Where are the phosphates more? ICF, right? And which is the major cation in the ICF? Potassium, right? And which is the major cation in the ECF? Sodium. Moving on to the Fick's law of diffusion. So Fick's law of diffusion, as we can see the graph here, so we have a linear curve which is the A. So linear one is none other than simple diffusion, right? It is the linear one. That means it only depends on the solute concentration. Till the solute concentration is more, Dero Dragon I will not be covering today. Go through B2B videos, right? Yes, no queries now. Please remember, we are here to revise. I can't answer all the queries now, right? So yes, simple diffusion, A is linear, right? It is governed by Fick's law of diffusion. What is Fick's law of diffusion? Let's have a look at Fick's law of diffusion. So Fick's law of diffusion, the B is facilitated diffusion. Why? Because there is a plateau. B is facilitated diffusion. There is a plateau, right? Facilitated. Yes, Satish, I'm ignoring. Don't worry. So let's move on to Fick's law of diffusion. The Fick's law of diffusion states I am not going to take doubts, don't worry, because this is a revision session. I can't help it. Even if I want, I can't take, right? So you have to bear with me. J is equal to minus D into A into delta C upon delta X, right? J is equal to minus D, absolutely correct, Karan Parekh. So where J is the rate of diffusion, J is the rate of diffusion, right? A is the area. Yes, you very well know a disease from respiratory medicine where area decreases, yes, and the rate of diffusion decreases. Where does the area decrease? The area decreases in emphysema, right? The area decreases in emphysema. ठीक? And delta C is concentration. Charcot-Marie tooth disease, Praveen Kumar, is the mutation of connexin. Connexin is forming a subunit of connexon, right? So what is the confusion there? Delta C is C1 minus C2 concentration gradient. Yes, absolutely correct. Concentration gradient. And delta X, remember, is the thickness of the membrane, right? Thickness of the membrane. Finally, we are left with D. So D is the diffusion coefficient. Diffusion coefficient is directly proportional to lipid solubility. Remember, it is the most important factor, and molecular size versus square root of molecular weight, right? Square root of molecular weight. So lipid solubility is the most important factor, right? Most important factor. So if I ask you that what is this? Yes, please quickly tell me what is this? Where I am seeing the peak of the saturation, right? What is this? This is my T max, right? This is my T max. What is T max? Transport maxima or transport maximum, right? Transport maxima or transport maximum. Yes, Karan Parekh, that's absolutely correct. Transport maxima. This is transport maxima, right? That means at this point I am achieving maximum rate of transport, right? Beyond this, there is no more molecule is going to get transported because all the carriers are saturated. Common example of facilitated diffusion, your glucose transporters, amino acid and urea. Let's have a look at sodium potassium ATPase pump now. Sodium potassium ATPase pump is a heterotrimer. Here two units are shown, but actually the recent advances tell us that it is made up of a third subunit gamma, whose basically the function is not yet properly told to us. So what happens here is beta is having 3 extracellular glycosylation sites. The beta subunit is the smaller subunit. Yes, and alpha subunit is the larger one. As we can see in the ECF, we have the binding sites, which is potassium and ouabane, right? Potassium and ouabane. But in the ICF, we have the sites, which is sodium binding site. This is ATP and this is phosphorylation site. Now some food of thought for you all. Yes, which is the phosphorylation site is made up of which amino acids? We do that in class. Yes, quickly. Which amino acid will get phosphorylated? Aspartate 376, right? Aspartate 376 is the amino acid which will get phosphorylated, right? Absolutely correct. So it's a heterotrimer. Let's move on to primary and secondary active transport. So what we can see here is that, on the basolateral side, which is towards the blood vessel, we have the sodium potassium ATPase pump, right? Absolutely correct, Aryan and Tanya Verma, Garima. So the sodium concentration decreases. From the other side, if the sodium and solutes are moving together, this is an example of co-transport or symport, right? Co-transport or symport. If the molecules are moving in opposite direction, this is antiport, right? Antiport or counter transport, right? Antiport or counter transport. Fine. So common examples of the secondary active transport. The secondary active transport, as you know, sodium glucose co-transporter, sodium amino acid, right? So common examples of secondary active are, so many examples we study in the PCT. We have the sodium glucose co-transporter. Then we have sodium amino acid co-transporter. Yes, we have sodium inorganic phosphate co-transporter, and we have sodium lactate. Absolutely correct, SGLT2 PCT. And we also have the thick ascending limb of loop of Henle, which I'm not mentioning here, which is my sodium potassium 2 chloride. So TAL DCT, right? Thick ascending limb of loop of Henle, we have sodium potassium 2 chloride co-transporter, and this is sodium chloride co-transporter, right? Absolutely correct, SGLT2, that is in the PCT, right? So moving on to one important one here, which is the sodium iodide symporter. Remember, sodium iodide symporter is present in, yes, antiporter, sodium hydrogen exchanger, sodium calcium. Absolutely correct. So I did not write this purposefully because most of you know it. Two examples are sodium hydrogen exchanger in the PCT. No. Pendrin is Karan Parikh, anion exchanger. It is not an example of secondary active. Pendrin is an ion exchange, right? Sodium hydrogen exchanger and sodium calcium exchanger in the heart, myocardium, right? Sodium calcium exchanger in the myocardium. So we have the sodium iodide symporter, which was asked in the previous exams. The sodium iodide symporter is present in the basolateral membrane, right? And the mnemonic, as I always tell in classes, remember when we are eating the chewing gum, then the parents used to tell you from the young age that don't swallow the chewing gum but spit it out. So the mnemonic is spit the gum, right? Spit the chewing gum. Yes, Bhavani, very good, absolutely correct. Where S stands for salivary glands and stomach, P for placenta, I for intestinal epithelial cell, T for thyroid, and G for gestational and lactating breast, right? So commonly they confuse by giving pituitary, which was the question asked in one of the inicet exams. P is for placenta, please remember that. And also remember that intestinal epithelial cell is present on the luminal side. Other ones are present on the basolateral side, right? Basolateral. No, it is not present in the testes, Ayush Agarwal. T is for thyroid, not testes. Nernst equation, let's look at the Nernst equation. We all remember Nernst equation is equilibrium potential is 61.5 upon Z, where Z is the valency of the ion, and C1 we remember always take the higher concentration, and C2 we always take the lower concentration, right? Higher and lower concentration. So basically what happens is Z is, U is nothing, Dr. Rohit Pant, spit the gum, G is for gum, U is nothing, right? So just to reiterate this concept of Nernst potential, I've given you one question. The sodium is 140 in the ECF and the sodium is 14 in the ICF. Then what is the equilibrium potential of sodium given? 2.3 RT upon F is 61. So they have given you everything. What I will write down here is that the Nernst potential of sodium is 61 upon 1, which is the valency of the sodium, into log to the base 10, 140 upon 14. So answer would be plus 61 millivolt over here, right? What happens actually if this is my cell? Then as we all understand, sodium is moving from higher concentration to lower concentration. This is ICF, this is ECF. Sodium is more outside. As the sodium moves in, more and more sodium along the concentration gradient, this becomes more and more, the inside becomes positive. This positive charge starts repelling the sodium ion a time comes when both the gradients become equal and opposite and the movement of sodium stops, right? When the concentration gradient becomes equal to electrical gradient, right? Okay, let's move on to some common values which you should definitely be knowing. Nurse potential of sodium is plus 61. It is plus 60. Over here it is plus 61 because remember it is given in the question. Yes, sign is denoted as per the inside charge. Absolutely correct. So this is plus 61. It is given as 61. So I'm not taking 61.5 because in the question they have given you 61, right? Moving on to the Starling forces, common values of Nernst potential of sodium is 61, chloride is minus 70, potassium is minus 90, right? Calcium is plus 125. Starling forces. What are Starling forces? This is shown as a tissue capillary. Yes. Valency of sodium is 1 Raghav Pandya. Starling forces, hydrostatic pressure in the capillary is a pushing force, right? Then we have the oncotic pressure in the interstitial fluid, which is again a force which will pull the fluid out. And then we have the hydrostatic pressure in the interstitial fluid along with oncotic pressure in the capillary, right? So Starling forces govern the filtration as we do in class. What can happen? Just to give you one more example here, if we have a patient of liver disease, right? Liver disease or cirrhosis. So what will happen in liver disease? Calcium is plus 125. Yes. So liver disease is 90 is potassium minus 90. Anushka, if you don't know the Nernst potential till now, I'm very surprised. Potassium is minus 90, right? Please go through our B2B videos. Potassium is minus 90. Chloride is minus 70. Again, I'm repeating. Calcium is plus 125, right? So liver disease, cirrhosis, what happened? The oncotic pressure in the capillary decreases. So what will happen? Yes, absolutely correct. More transudation of fluid. More fluid transudation means anasarca, generalized edema, right? Anasarca, right? Starling forces. It is a very important force. It governs the pressure. Also, it is the reason for pulmonary edema and the pedal edema when we have the left and right ventricular failure, right? Plus 61 is for sodium. Moving on to the nerve physiology, we have the exoplasmic transport as shown by the figure. I want you to remember some facts. The exoplasmic transport can be either fast or slow. The exoplasmic transport can either be fast or slow. So it can either be fast. Fast is basically the speed of transport. Slow, the speed is less, right? So the fast transport is both anterograde and retrograde. Anterograde means moving in the forward direction from the cell body to periphery of the axon, and the retrograde is in the opposite direction from the periphery of the axon to the cell body. The anterograde is called as fast because it has a speed of 400 millimeter per day. The retrograde is again having a speed of 200 millimeter per day, right? 200 millimeter per day. Basically, the anterograde transport, which is either, the fast is 400 millimeter per day. This is used for transporting various endoplasmic reticulum, mitochondria, endoplasmic reticulum, and various vesicles, right? And which molecular motor is used by the anterograde transport? So anterograde transport uses kinesin, and the retrograde uses, doesn't matter Dr. Tanisha, you will get the PDF, don't worry, dynein. Remember, how do I remember this? As I told you, RD is radio diagnosis, right? So most of the people, they will like to go for RD or radio diagnosis, right? RD is radio diagnosis, right? And we have the another transport, retrograde. Commonly remember, the retrograde transport is used by our neurotropic viruses. zootropic viruses such as herpes, rabies, and poliovirus. Herpes, rabies, and poliovirus, right? Also used by tetanus toxin. Also used by tetanus toxin, right? So even tetanus toxin will damage your cell bodies, right? Absolutely correct. Moving on back now to the slow. Slow is always enterograde. Slow is always enterograde. Enterograde is 0.5 to 10 millimeter per day, right? It is very slow. So moving on to the next one, phases of action potential. Phases of action potential is as you can see the figure here, at point B, which is almost at the peak of the action potential depolarization phase. So I can say that at this point, at point B, the nurse potential, the membrane potential is closest to nurse potential of sodium, right? And at point D, why? Because nurse potential of sodium is how much? Plus 61, right? And at point D, 0.5 to 10 millimeter, please write down quickly, 0.5 to 10 millimeter. Enterograde is always slow. And at point D, the nurse potential is closest to nurse potential of potassium. It is close to nurse potential of potassium, right? That is at point D. Yes, Abhishek Roy, that's correct. The A to B is depolarization occurring due to sodium influx, and then B to C is, remember, voltage gated sodium channels, fast to open, fast to close. This concept is used in the next slide where we have the membrane conductance for sodium and potassium during different phases of action potential. So this is which ion? This is my ion which is fast to open, fast to close. This is sodium. And this is potassium. Then we have the strength duration curves. No, Dr. Karamvi, don't worry, we'll finish by 9 o'clock. Don't worry, right? We'll finish by 9:15. Don't worry. Strength duration curve. What is strength duration curve? Strength duration curve is the Rio base, which is the minimum strength of the current, which when applied for prolonged duration. The key word is minimum strength. So this is now, this much is Rio base, right? And this now utilization time is the time taken by Rio base current to stimulate. And Cronexi, please make a correction here. This is a typo error. Time taken by a 2R. That means twice the Rio base current, right? So please make this correction. This is a typo mistake. Time taken by twice the Rio base current. Twice the Rio base current. So if this is R and I do double, then naturally this is my Cronexi, right? This is, now this becomes 2R, because this is R, this will become 2R. So this becomes 2R and the Cronexi will be this much. So this becomes my Cronexi, right? What is Cronexi? Time taken by double the strength, right? Double the strength. So this becomes Cronexi, C, right? So Cronexi is the time taken by double the strength of the Rio base current to stimulate or produce a response. What is the significance of Cronexi? Lesser the Cronexi, greater is the excitability. Lesser is the Cronexi, remember, has come from the word Crona, time. Lesser is the Cronexi, greater is the excitability. Lesser is the Cronexi, greater is the excitability. Remember, if a nerve is getting stimulated in lesser time, that means it is more excitable. That's it, right? And commonly we say that Cronexi of the nerve is less than Cronexi of the skeletal muscle, which is less than Cronexi of the cardiac muscle which is further less than chronexy of the smooth muscle. That means which is the most excitable out of all the four. The nerve is the most excitable, and which is the least excitable? The least excitable is going to be my smooth muscle, right? Now moving on to the factors which affect nerve impulse conduction. Remember, two factors affect the nerve impulse conduction. Diameter of the nerve fiber, greater is the diameter, more is the velocity of conduction. Generally we say in the unmyelinated nerve fibers, the velocity of conduction is proportional to square root of d. D is the diameter of the fiber. And in myelinated, the velocity is proportional to 6 into d, where d is diameter of the fiber, right? D is the diameter of the fiber. Where d is the diameter of the fiber. So basically myelinated nerve fibers will give a linear relationship between velocity and the diameter, and this is mathematics, nothing to do with physiology. The square root will give a parabolic relationship. The square root will give a parabolic relationship, right? Parabolic. Myelination is another important factor which increases the velocity many times. So in myelinated, I've already told you that in myelinated the velocity is increasing, almost 6 into d. This is only square root. Yes, so myelination we have done. Susceptibility of the nerve fibers. Susceptibility of the nerve fibers, pressure is A, B, C. Remember, thicker the fiber, more is the susceptibility to pressure. Most thickest fiber is A alpha, that is maximally being susceptible, right? And A alpha is also can be asked as a question is Saturday night palsy. For hypoxia, the order is BAC, right? For hypoxia, the order is BAC, and for local anesthetics, the order is again ABC, where A gamma is the most susceptible, right? Moving on to skeletal muscle physiology. So we have a figure in which everything is written for you. Just do a quick recap. So we have a presynaptic membrane disease, which is Lambert-Eaton syndrome, autoantibodies to voltage gated calcium channel, myasthenia, autoantibodies to the against acetylcholine receptors, right? So what happens here? Initially the action potential arrives. As the action potential travels, the voltage gated calcium channels open. There is increase in calcium influx, which causes opening of through the voltage gated calcium channels, the calcium influx occurs. Then acetylcholine molecules come out. As the acetylcholine molecules come out, they bind to its receptor and causes opening of both ligand gated sodium and potassium channels, right? Moving on to the arrangement of sarcomeres in a myofibril, you know that in the relaxed state, this is the muscle shown, this is the Z band or Z line, right? It's the same thing. Generally, we use the term Z line. So what happens here? So as during muscle contraction, as you can observe, what is happening, the width of I band, decreases, right? The H band disappears, the M line becomes prominent. A gamma is most susceptible to local anesthetic, and the A band remains unchanged. The A band remains unchanged. A band remains unchanged. It remains same, right? Unchanged. Moving on to the excitation contraction coupling. Yes, that's correct, Sheendhar. So excitation contraction coupling, the most important thing I want you to remember here is through the figure action potential is conducted. Remember, we have the dihydropyridine receptor on the T tubule. The theory which you need to recall here is electromechanical coupling. Electromechanical coupling. Why are we calling it as electromechanical coupling? Because there is mechanical linkages between dihydropyridine and ryanodine receptor, right? There are mechanical linkages between dihydropyridine and ryanodine receptor. Dihydropyridine receptor, if I ask you, yes, quickly write down in the chat box. Let's do some question. Yes, dihydropyridine in the skeletal muscle is a voltage gated calcium channel, or is a ligand gated calcium channel, or is it a voltage sensor? What do you say? Quick. DHPR, remember, in the skeletal muscle is a voltage sensor, right? Voltage sensor. So what happens here? Action potential is conducted, the linkages move away, calcium comes out, and then eventually calcium is pumped back via the circa, right? That is the mechanism of relaxation. Absolutely correct. Very good, everyone. Sliding filament theory. So we are starting from here. Step number 1. The myosin is energized, ready to bind to actin. Myosin binds to actin, formation of actomyosin complex. Myosin head flexes. What is this known as? Power stroke, right? Flexion of the myosin head, the actin slides. Then ATP binds. As soon as the ATP binds, there is dissociation of actin from the myosin head. Okay, Divya Lakshmi, there is dissociation of actin from the myosin head, right? And once finer thickness of pen. Okay, Harsh, I will try to do that. So yes, so dissociation of actin from myosin head. Myosin again, comes back to the original conformation, and the first step, then there is the second one, third, and the steps continue. This is known as which theory? Sliding filament theory, right? Sliding filament theory. Moving on to the length tension relationship, or the Frank-Starling law. So we commonly observe it during an isometric muscle contraction. More is the initial length, more is the tension generated, but only up to a physiological limit, beyond which further increase in length decreases the tension generated, right? So this length at which the tension generated is maximum is known as optimum length. Optimum length. Optimum length is also known as resting length in humans, and optimum length is the length of the muscle at which, if a muscle contracts isometrically, right, the tension generated is maximum. Okay, Atharva Patil, I'll go slow. Tension generated is maximum. So why is the tension generated maximum? Because at this point there is maximum actin myosin overlap. There is maximum actin and myosin overlap, right? That is known as the optimum length. Optimum length, right? At this there is maximum actin myosin overlap, right? And what is the optimum length at which the tension generated is maximum? It corresponds to a sarcomere length of 2 to 2.2 micron. 2 to 2.2 micron, right? Then we move on to tetanyzing frequency. Remember, tetanyzing frequency is always 1 upon the contraction period. The key word is contraction period. You have to take in second. Generally, they always give in millisecond. So let's say this is 5, this is 40, right? So up till 0 to 5 is the latent period. Please do not include latent period, which is the period between the point of stimulus to the point of response, right? So 2.2 to 2.2 micron. I've already written that, right? So moving on to tetanyzing frequency, right? 1 upon contraction period in second. Up suppose yahan pe you have to calculate. Then remember, this is the peak height of contraction. This entire from 5 to 40 is my contraction period. That means the answer would be 1 upon 35 millisecond, right? If I solve this further, the answer would be 1000 upon 35, right? Which would be approximately 30 hertz, right? That is how I can calculate, right? So 1000 upon 35. That's correct, Dr. Unithan and Aditya. Moving on to renal system. So in the renal system, the first thing is glomerular filtration rate, which we all know is 125 ml per minute or 180 liters per day. So it is 3 layers are there in the glomerular filtration membrane: glomerular capillary endothelium, basement membrane, and the visceral layer of the Bowman's capsule, which is also known as podocyte layer. Right? So which are the factors affecting glomerular filtration rate? The glomerular filtration rate is hydrostatic pressure in the glomerular capillary. As you can understand, this is a pushing pressure. So I am highlighting the ones which are acting in the same direction. We have oncotic pressure in the Bowman's capsule, which is again a pulling pressure. Then what happens is we have the oncotic pressure in the glomerular capillary and hydrostatic in the Bowman, which is pushing the fluid back. So what is the net filtration pressure? The net filtration pressure is the hydrostatic pressure in the glomerular capillary plus oncotic. We are adding them together, minus oncotic and minus hydrostatic in the Bowman's capsule, right? So glomerular filtration rate is equal to the Kf into net filtration pressure. Yes, net filtration pressure is, if you solve this, you will get the answer. This is around 45 minus 25 minus 10, and this is 0. So the answer would be 10 millimeter mercury, right? What is Kf? That is ultrafiltration constant or coefficient. Moving on to the auto-regulation of the GFR. The GFR is auto-regulated between the value of 90 to 200 millimeter mercury of mean arterial pressure. Remember, whenever we talk about the pressure, it is always mean arterial pressure, right? So when we talk about mean arterial pressure, there are 3 mechanisms for filtration coefficient is Kf, right? Please refer to the B2B notes. I can't explain you here the Kf, right? So we are here to do the revision. So there are 3 mechanisms for auto-regulation of the GFR. The myogenic mechanism, myogenic, that means something related to smooth muscle. Remember, more is the GFR, more is the stretching of the vascular smooth muscle of the afferent arteriole, right? More is the stretching of the vascular smooth muscle of the afferent arteriole, right? VSM is vascular smooth muscle. More is the stretching of the vascular smooth muscle of the afferent arteriole. This will lead to increased opening of stretch sensitive calcium channels. Increase opening of stretch sensitive calcium channels, and this will now cause increased calcium influx, which will lead to vasoconstriction of the afferent arteriole, resulting in decrease in GFR, right? This is the first one. Let's move on to the tubuloglomerular feedback. Tubuloglomerular feedback is the feedback exerted by the tubules on the glomerulus. So let's look at the figure. More is the GFR, we are starting from here. More is the GFR, more is the sodium chloride load in the tubular fluid, because remember, PCT cannot reabsorb. Okay, I'll use the thinner pen. So more is the sodium chloride load in the tubular fluid. Yes, Dinesh Raja. So it will be sensed by macula densa. The macula densa is present in the early DCT, right? Then we have more sodium chloride reabsorption. What is the mechanism of sodium chloride reabsorption in the DCT? The mechanism is secondary active. Secondary active. I'll just show you the last slide. Just give me a minute. Secondary active. Secondary active means I will be breaking down more sodium potassium ATPase. More sodium potassium ATPase means increased ATP hydrolysis. Increased ATP hydrolysis means more generation of adenosine, Adenosine acts on A1 receptors, which causes calcium release, again constriction of afferent, decrease in GFR, right? Last slide, please have a look. More is the GFR, more stretching, more opening of the stretch sensitive calcium channels, more calcium influx, vasoconstriction, decrease GFR. Then we have glomerulotubular balance. Glomerulotubular balance is basically with increase in GFR, there is increase sodium chloride reabsorption in the PCT, right? Then moving on to clearance. Clearance is the volume of the plasma that is removed of a substance. Clearance is the volume of the plasma that is cleared or removed of that substance in 1 minute, right? So it is UV upon P, urinary concentration, V is the urine flow rate, and P is the plasma concentration. We all know clearance of inulin is equal to GFR. Clearance of pH at low concentration is renal plasma flow. Why at low concentration? Low concentration means only when the concentration is less than 20 milligram per deciliter. GTB is glomerulotubular balance. Glomerulotubular balance. And what is the Tmax for pH? Tmax of pH value is 80 milligram per minute. Yes, have a look at GTB slide, please. Yes, glomerulotubular balance. Glomerulotubular balance. Then this is a standard figure of clearance figure. If this is a standard figure of the clearance curve, so what happens in the clearance curve is that what we say is this is a line, straight line, which is representing the clearance of inulin. C is the inulin here. RPF is renal plasma flow, jagah nahi thi. Inulin. Then anything which is more than inulin, anything which is less than, more than inulin is a substance which is always secreted, right? Always secreted. Anything which is less than inulin line or below the inulin line is always reabsorbed substance. Now amongst the given choices, the A is para-aminohippuric acid, that is the right answer. The B is creatinine because it is slightly more than inulin. The C is inulin, and D over here is glucose, right? I can ask you one question which came recently in one of the exams. Yes, creatinine is partly secreted. What is this for glucose? Quickly write down the answer in the chat box. Yes. And please tell me something good now. Yes, the right answer. What is this? This is that concentration of the glucose, plasma concentration, up to which no glucose appears in the urine. That means clearance is 0. Yes, what is this? Please boliye fatafat, quick. What is this? Yes, Farah Khan, absolutely correct. Good. Renal threshold of glucose. This came in one of the recent exams, right? 180 milligram per deciliter. Renal threshold of glucose. That's absolutely correct. 180 milligram per deciliter in the venous blood. Moving on to the tubular handling of different substances. Yes, so what we say here is that it is this should be hormone regulated. I'll just finish that for you. This should be hormone regulated segment. This is segment is written. Hormone regulated segment. Hormone regulated segment is my collecting duct, because all the hormones act on collecting duct, right? This should be hormone regulated. So as you can see that in the PCT, the urea is reabsorbed 52%. Electrolytes and water are reabsorbed in the same proportion. So at the end of PCT, the tubular fluid is isotonic. At the end of PCT, the tubular fluid is isotonic, right? Then what happens? The descending thin limb of loop of Henle. The descending thimb of loop of Henle. This is only permeable to water. Yes, I've changed the tip of the pen. Sorry about that. So because it is only permeable to water, in this connecting tubule, this becomes hypertonic. So it becomes hypertonic in the connecting tubule. And as the hypertonic fluid moves above, remember the thin ascending, thick ascending are only permeable to solutes. So in the DCT, in the early DCT, it is hypotonic. In the early DCT, this is hypotonic. So in the early DCT, the tubular fluid is hypotonic. Yes. Thick ascending limb is known as the diluting segment of the nephron. The better answer sometimes is the medullary diluting segment. Medullary diluting segment. And DCT is called as cortical diluting segment. The reason is that the thick ascending limb of loop of Henle is only seen in juxtamedullary nephrons, right? Renal handling of sodium. So filtered load of sodium is equal to glomerular filtration rate into plasma concentration. This is 180 liters per day into 140 millimole. So this would be 25,200, right? First question, sodium is reabsorbed in all the segments of the nephron except descending thin segment. Why? Because it is only permeable to water, right? This is only permeable to water. Moving on to sodium reabsorption in the PCT, around 60% as we say, 60 to 70 is the range. So sodium potassium ADPase is located on the basolateral side. This is basolateral. This is the luminal side. So sodium and the solutes move in the same direction. Secondary active cotransport. Now I have written all the examples. Sodium glucose cotransporter, sodium amino acid, inorganic phosphate, which is the major one, SGLT2. Secondary active counter, sodium hydrogen exchanger. Which diuretics act over here? Carbonic anhydrase inhibitors. Thick ascending limb of loop of Henle, sodium potassium ADPase, again basolateral side. Again this is the that acidic, I'll tell you in a while, Sai Rama. I'll just wait for a while. I'll discuss in a while. DTS is descending thin segment, which is also known as thin descending limb of loop of Henle. So then the potassium, some of the potassium leaks back via the ROMK channels. ROMK is renal outward medullary potassium channels. Renal outward medullary potassium channels. This potassium which comes out again enters back. This is commonly known by the term recycling of potassium. Recycling of potassium, right? This is known as recycling. And the chloride moves via chloride channel KB, right? Mutation of NKCC, Bartter syndrome, right? Mutation of NKCC, Bartter syndrome. 140 is the average sodium concentration in the ECF, right? DCT, sodium chloride cotransporter. Which diuretics inhibit the DCT? The sodium chloride cotransporter, yes. Which diuretics inhibit the sodium chloride cotransporter? The answer is the thiazides, right? Which diuretics inhibit the sodium potassium 2-chloride cotransporter? Yes, quickly. Which diuretics inhibit this? Sodium chloride, yes, loop diuretics, right? Loop diuretics. Then we have the aldosterone induced sodium reabsorption which occur in the late DCT and the P cells of the collecting duct. So aldosterone receptors are present in the cytoplasm, right? Cytoplasmic. Aldosterone receptors are, Barter is mutation of, medicine में पढ़ा है आपने अभिषेक, this is taught in medicine. Barter is mutation of NKCC, right? So we have the aldosterone receptors are cytoplasmic. Gentleman is mutation of NCC. Mutation of NCC, Gentleman. Mutation of NCC, Gentleman. Basolateral is towards the blood vessel. This is Gentleman. Right? Then we have the aldosterone. What will happen? Sodium potassium ATPase. The enax is epithelial sodium channels through which the sodium moves in. We have the diuretics which can inhibit the enax. Yes, which are the diuretics which inhibit the enac? And we have the diuretic which directly inhibit the aldosterone. Yes, so we have, these are the potassium sparing diuretics. This is amiloride. And this is spironolactone. Yes, absolutely correct. Triamterene, amiloride, spironolactone. That's correct. And remember that once the sodium moves in, the luminal potential becomes highly negative. The luminal potential becomes highly negative. So what will negative charge do to positive potassium? This is negative. The negative charge will cause passive secretion of potassium, right? Passive secretion of potassium. Gain of function mutation of ENaC is known as Liddle syndrome. Yes, most of you are writing that correctly. Gain of function mutation of ENaC is Liddle syndrome. That is the right answer. Gain of function mutation of the ENaC is Liddle syndrome, right? Liddle. Let's move on to renal handling of potassium. Remember, potassium is the only ion which is both reabsorbed and secreted, right? It is the only ion which is both reabsorbed and secreted. Reabsorption of potassium occurs in PCT and thick ascending limb of loop of Henle. Around 90% of potassium is reabsorbed, right? And less than 10% of potassium reaches the DCT and the collecting duct, right? Less than 10%. So secretion of potassium occurs in the collecting duct. It is aldosterone induced. Already we have discussed that, right? So remember, the most potent stimulus for aldosterone release is hyperkalemia and not RAS. Please remember this question. The most potent stimulus for the aldosterone release is hyperkalemia. Hyperkalemia is the most potent and not the RAS. Most potent is the hyperkalemia, although RAS will also stimulate the release of aldosterone, right? Renal handling of glucose, as we can see, glucose is 100% reabsorbed in the PCT. The major pump is the SGLT2 and the GLUT2, right? Sodium dependent glucose transporter and the glucose transporter 2. What is the Tmax for the glucose? 375 milligram per minute, right? And now 90% of glucose is reabsorbed due to SGLT2 and GLUT2, right? So the major one is SGLT2 and the GLUT2, right? SGLT2 and GLUT2. Discussing the renal handling of water further, the water is of two types. Remember, obligatory versus facultative reabsorption of water. So obligatory reabsorption of water occurs in two places. One is PCT as shown in the figure. The PCT I reabsorb. Yes, absolutely right, Sahil Rathore. Just remember 90% is the SGLT2 and GLUT2. So 65% of the water is reabsorbed in the PCT. Yes, that's correct. More 65%, or we say 60 to 70 is the range. And around, as it is written, 15 to 20% in the, the thin descending limb of loop of Henle. Which are the aquaporins present? Let's revise. Aquaporin 1 in both the places. So basically the total is, I have explained in back to basic videos, Amira, kindly go through it. So 80, we say the obligatory water reabsorption is 85%, right? 85% of water is absorbed obligatorily. 85% is obligatory, right? 60 to 70 in PCT and another 15 to 20 in the thin descending limb of loop of Henle. That is obligatory, which will occur always. So which is the site where maximum water is reabsorbed? Which is the site where maximum water is reabsorbed? The answer is PCT, right? So then we have the ADH, under the influence of which vasopressin, the facultative water reabsorption occurs. How much water is reabsorbed? Additional 13 to 15%. But additional 13 to 15%. And we say that this is the main aquaporin here is aquaporin 2. Aquaporin 2. Aquaporin 2 is the aquaporin. So ADH only causes increased synthesis of aquaporin 2. ADH only increases the synthesis of aquaporin 2. So where is the location of the aquaporin 2? Yes, quickly tell me the location. Aquaporin 2. Yes, location of the aquaporin 2. Quickly. Yes, aquaporin 2 location. Is it on the luminal side of collecting duct? Is it on the basolateral side of the collecting duct? Where? Aquaporin 2 location. Because remember, yes, absolutely correct, Sheendhar. It is only on the entire luminal side of the collecting duct, right? No. Basolateral is aquaporin 3 and 4. As we do in class, please go through the back to basic videos. Aquaporin 3 is in the basolateral of the cortical collecting duct. Aquaporin 4 is in the basolateral of medullary collecting duct, right? I have explained that in the back to basic videos. So please remember only aquaporin 2. Somebody was asking me acid secretion. Yes, Akul Mittal, absolutely correct. Hydrogen secretion in the cortical collecting duct is aquaporin 3. Aquaporin 4 is the medullary collecting duct. Both are on basolateral side, right? Moving on to acid secretion. Somebody was asking me about the acid secretion. Daily secretion. So we have the PCT in the proximal convoluted tubule. We have the daily secretion 4200 millimole per day. Collecting duct we have less than 80 millimole per day. Carbonic anhydrase is maximum. Carbonic anhydrase is present in higher concentration in the PCT. In the collecting duct it is present in the less amount, right? Actually, please don't use, have some manners. Don't use disrespectful words. If you do not know a thing, then please don't attend, right? But please don't, don't talk rubbish here, right? So moving on to mechanism of hydrogen ion secretion. In the PCT, we have the secondary active counter transport. Can you tell me the name of the counter transport in the PCT? Yes. Yes, don't whine. Whine is the correct word which somebody has used. I didn't want to use that. Yes. So secondary active, yes. Can you tell me the name of the counter transporter? We have already discussed that. Sodium hydrogen exchanger, right? And what is the primary active transport? The primary active transport is hydrogen ATPase and hydrogen potassium ATPase. Remember, it is a revision session. I am not here to explain you and teach you things. I expect you to know the things, as majority is giving me the right answer, right? Then which is the buffer here? Bicarbonate, phosphate and ammonia. Acidification of urine mainly occurs where? In the collecting duct. Main site of acidification of the urine is collecting duct. And yes, if you are not able to, understand, it is not my fault. Please go through the back to basic videos. Rather, you should have gone by now, right? Today is the DVT session, revision. So acidification of urine mainly occurs in collecting duct. And remember, what is the reason? Because in the PCT, we have lots and lots of bicarbonates. Anyone who can tell me what is this term known as? In the why there is no acidification of urine in the PCT? Yes, what was the term? Anyone who could say yes? Quick by handling by the bicarbonate. Quick by handling by the bicarbonate, right? So quick by handling by the bicarbonate. Quick by handling by the bicarbonate. I'll just revise, just give me 1 minute. Quick by handling by the bicarbonate. Absolutely, Dr. Meenakshi Jha, that's correct word. So what I want you to know is that although PCT is maximum hydrogen ion is secreted because there is lots and lots of carbonic anhydrase here, and we have the secondary active transport. I've already highlighted for you sodium hydrogen exchanger, and why it is not able to acidify the urine because of quick by handling by the bicarbonate. Right, collecting duct is the site where mainly acidification occurs because there is no bicarbonate to bihandle. So no bicarbonate to bihandle, right? So last point, for every hydrogen ion secreted in the PCT, we have one bicarbonate which is reabsorbed, but the new bicarbonate is only generated in the collecting duct. Yes, I will request you, if you are not able to understand this table, please go through once back to basic videos. In the last, I will give you my WhatsApp number. You can send me the query directly on my WhatsApp number, right? Moving on to cystometrogram. Cystometrogram is a figure which illustrates the filling of the bladder along with, as you know, we drink the water, there is filling of the bladder. So what happens is, it is called as the pressure changes in the bladder along with filling of the bladder. Yes, NH is sodium hydrogen exchanger, Bandana. So intravesical pressure, pressure in the bladder, intravesical volume. Absolutely correct, Anushka. Very good, correct answer. The cystometrogram has 3 phases, 1A. In 1A, we are saying, in 1A, we say as the bladder fills up to 50 ml. So as the bladder fills up, yes, absolutely correct, Akul Mittal. As the bladder fills up, most of you are able to give me the right answer. That's really good. So as the bladder fills up to 50 ml, as we can see from the figure, this is known as phase 1A. This is the filling almost up to 50 ml. Then what happens is the pressure rises to 10 centimeter water, right? The intravesical pressure rises to 10 centimeter water. Then what happens is that phase 1B, what you can observe is that up to 400 ml, although the bladder is getting filled up, but in the phase 1B, it is known as flat part of the curve. Flat part means that, you know, the pressure is not changing, although the volume is rising. What happens? P is equal to the 2T upon R. Now what happens is, as the bladder fills up, the tension increases in the bladder, but because of stretching of the smooth muscle of the bladder, the radius also increases. This is which law? Most of you have written the right answer. That's really good. Laplace law. And what happens here? Both tension and radius increases. Why is the radius increasing? Because of the stretching of the bladder, which is the property of plasticity. So I can ask you, what happens after 400 ml? Remember, after 400 ml is the phase 2. In the phase 2, what I observe is that beyond 400 ml, there is a huge increase in bladder pressure. Beyond 400 ml, the pressure rises to almost, you see the pressure is quickly rising to almost 30 to 40 centimeter water. There is a quick rise. Now why is beyond 400? There is a quick rise because remember, bladder has a maximum stretching capacity. Beyond 400, the bladder cannot stretch more, right? And there are two more questions as a lot of people are writing in the chat box. Let me tell you that as well. The first urge to void occurs at a volume of 100 to 200 ml in the bladder. That means the middle value would be 150 ml. And beyond 400 ml, we cannot hold the urine. Beyond 400 ml, we cannot hold the urine, right? That is beyond 400 ml, right? So this is cystometrogram. They can either ask you plasticity or the Laplace law. Moving on to the cardiovascular system now, which is the plateau potential. Yes, R is the radius, throat Manasi, absolutely correct. R is the radius, it could be nothing else. And P is the pressure, T is the intravesical tension. Dotted line represents that, had the bladder basically being further stretched, what would have happened? Then the pressure would not have increased further. They are only telling you if the bladder had more capacity, then the pressure would not have raised quickly. That is the only thing they are showing by the dotted line. So plateau potential. Plateau potential, phase 0 is depolarization, already mentioned in the figure. The depolarization is due to, yes, which ion? Please write down in the chat box. Now you tell me the answer. Depolarization is due to sodium influx. After phase 2, Rahul Rathod, the patient will void the urine. He cannot hold the urine, right? He cannot hold the urine. Phase 0 is depolarization, sodium influx. Phase 1 is potassium efflux. Yes, can anybody tell me the name of the channel which I have told you in the class and in the notes? Yes. Phase 1 repolarization, early repolarization. Can you tell me quickly which is the potassium channel? Remember the name is TROP. Yes, transient rectifier, absolutely correct. Transient rectifier outward potassium channels. Transient rectifier outward potassium channels. That's correct. Yes, most of you are writing the correct answer. That's really good. Phase 2, which is a recent question of the exam, plateau potential. The phase 2 or the plateau potential is due to, yes, drop and drop. Good, Jayant, good. So phase 2 or the plateau is due to slow calcium channel. Absolutely correct. Somebody has given me all the answer. That is the way to revise. Phase 3 is again due to potassium efflux. This time the answer is drop. Delayed rectifier outward potassium channel. Only one word changes, delayed. And then we have the phase 4, which is slower closure of potassium channels. Slower closure of the potassium channels, right? Slower closure. Let's move on to, so two phases are important here which you all should remember for the exam. One is the phase 0 depolarization, another is plateau, right? TROP is delayed rectifier outward potassium. Moving on to pacemaker potential. Yes, Fatima Nizar, absolutely correct. Phase 0 or depolarization in the pacemaker is due to calcium. Which calcium channels? Can anyone tell me? Yes, quickly. I'm waiting for your response. Which calcium channel in the pacemaker potential? Yes, I'm waiting for your response quickly. Yes, quickly. Sodium is Deep Prakash Bhai. Sodium is sodium influx. That's it. Funny current to bhi aayega. No. Phase 0 depolarization is due to, no, it is L type. L, long lasting. Calcium LL. Long lasting. Okay. Phase 3 is always due to potassium efflux. Let's move to phase 4. Phase 4, as you know, is due to, it is also known as pre-potential phase. Pre-potential. Okay, let's have a look at phase 4. I'll write it probably over here for you. Phase 4. Yes, most of you are giving me the right answer. Phase 4 is due to slower closure of the potassium channels, increased, yes, funny sodium, absolutely correct, good. Increased opening of, I was waiting for that answer, increased opening of NaH or funny sodium. Increased opening of NaH, or also known by the name funny sodium. And finally we have increased opening of calcium T, transient calcium, right? Transient calcium. That takes care of the phase 4. Moving on to cardiac cycle. Now one interesting mnemonic to share here. As you can see that we have the representation of all the heart sounds. Yes, Anu, HCN is same as sodium H, hyperpolarization induced. So here we have the heart sounds S1, S2. What is the mnemonic to remember the cardiac cycle? Remember PA4. 4 is the S4, QR1, CX, T2, V3Y. This corresponds to Y, and the second heart sound corresponds to dicrotic notch. What is the mnemonic? One line mnemonic to remember the cardiac cycle. Very good, Vishal Bhattar. Good, you are able to recall for me. पान की दुकान पे, PA is पान, पान की दुकान पे. QR कोड स्कैन किया, QR is QR कोड स्कैन किया. 1C, एक सिगरेट जलाई. एक्सरे में T2 की फाइंडिंग आई, V3Y, राइट. पान की दुकान पे, अगेन आई एम रिपीटिंग, पान की दुकान पे एक QR कोड स्कैन किया, एक सिगरेट जलाई, एक्सरे में T2 की फाइंडिंग आई, V3Y, राइट. सो व्हाट इज द mnemonic? PA is पान की दुकान, QR is QR कोड स्कैन किया, 1C is एक सिगरेट जलाई, X is एक्सरे, T2 की फाइंडिंग आई, V3Y, right? You want me to write in Hindi? Okay, I'll write down the mnemonic in Hindi. पान, PA is पान, right? पान की दुकान पे, right? That is the mnemonic. QR कोड स्कैन किया, राइट. QR कोड स्कैन किया. 1 is एक सिगरेट जलाई, राइट. एक सिगरेट जलाई एंड एक्सरे में फाइंडिंग आई T2 V3Y, ठीक. सो ये हो गया हिंदी में. यस, राइट. वेरी इजी वे टू रिमेंबर सच अ डिफिकल्ट थिंग. होपफुली इट विल हेल्प अस इन एग्जाम एज वेल. इट शुड, राइट. सो पान की दुकान पे QR कोड स्कैन किया, एक सिगरेट जलाई, एक्सरे में फाइंडिंग आई T2 V3Y, ठीक. डाइक्रोटिक नॉच corresponds to second heart sound. After 3 I will have Y, right? Y. So I have written the mnemonic in Hindi. Yes, right. And I have repeated all again for you, right? Let's move on to cardiac output. Cardiac output is the left ventricular output is same as right ventricular output, as you know. Yes, Sahil Rathod, that's absolutely correct. And cardiac index is cardiac output divided by the body surface area, right? So normally the standard value of cardiac output is 3.2 liters per minute per meter square. 3.2 liter per minute per meter square. 3.2 liter per minute per meter square, right? That is cardiac index is cardiac output per body surface area. This is the normal value. Cardiac output we also know is stroke volume into heart rate, right? Cardiac output is also stroke volume into heart rate. And remember, cardiac output is also 4 is fourth heart sound. Fourth is Rakesh Kumar, fourth heart sound. That is not physiologically heard. It is a pathological heart sound, right? So cardiac output is mean arterial pressure upon total peripheral resistance. So what happens here is this formula I have derived from Q is equal to delta P upon R. delta P upon R, where remember this is the Ohm's law derivation from hemodynamics. So Q is cardiac output. Q is cardiac output, right? Delta P is the mean arterial pressure and the R is the total peripheral resistance, right? So this is the Ohm's law interpretation which we do in hemodynamics, right? Regulation of the cardiac output, yes, 3.2 liter throat Manasi, that is cardiac index. Regulation of the cardiac output, Neeraj, I'm maintaining my speed, hai na? So I have to take care of all of you, not only one or two people here, right? As Dr. Deepti just mentioned, so kindly have a little patience. TROP is transient rectifier outward potassium, right? Regulation of cardiac output depends on two factors, factors which regulate heart rate. Common factors which regulate heart rate are your vagal and sympathetic stimulation. Sympathetic stimulation, yes, that's correct. And the vagal stimulation, remember, will decrease, right? Thank you, ma'am. So vagal stimulation will decrease and sympathetic stimulation is stimulatory, right? That is the first factor which can regulate the heart rate. Factors regulating stroke volume. The stroke volume is regulated by myocardial contractility and venous return. Remember, venous return we study in length tension relationship. Yes, we know this. Electrical events are followed by mechanical events. Venous return more is the preload, or more is the end diastolic volume. More is the preload or more is the end diastolic volume. Yes, Frank-Starling law, absolutely correct. Sahil Rathore, that's correct, Jayant. So more is the tension generated. More tension generated. But remember, only up to a physiological limit. So this is known as Frank-Starling law, right? Frank-Starling law, right? Frank-Starling law. So just to illustrate this one, we have a graph to see. So as the preload is increasing, the cardiac function or the stroke volume increases. But remember, then there is a plateau because it only occurs up to a physiological limit. Now we have a case where I have increased cardiac function. How can cardiac function increase at the same preload? That means if in a normal person, the preload is same, but now the output has increased. So how can output increase at the same preload? That means most likely, we have increased the contractility, or I have given the patient digitalis, which is positive inotrope, right? So I have given the patient digitalis. I'm just showing the last slide, Shreya Pandey. Just give me a minute. Yes, we have given the patient digitalis or positive inotrope, right? Decreased cardiac function. Now the function is less than normal, rather much lesser. How can it happen? Most likely it is the loss of the myocardium, right? Commonly occurs after myocardial infarction. Yes, somebody wanted to see the last slide. Please have a look. More is the preload, more is the tension generated, but only up to a physiological limit. And the same concept I have shown you with the help of a figure, right? Up to a physiological limits. Yes, moving on to venous return, very interesting curve here to discuss. Venous return is now, what is PSF? That is mean systemic filling pressure. So I can write down it like this. Venous return is equal to mean systemic filling pressure minus right atrial pressure upon resistance to venous return. Right, so this again formula, remember, is coming from the same derivation. Q is equal to delta P upon R. So if the blood is returning from the systemic veins into the right atrium, it will have some resistance due to right atrial pressure. So mean systemic filling pressure minus RAP. So mean systemic filling pressure is the pressure measured everywhere in the circulation once the heart stops beating, right? So when there is no blood in motion, as we say. Decreased cardiac function would be loss of myocardium. It can commonly occur post MI, after or post myocardial infarction, right? So moving on to the formula, a time will come when the venous return becomes zero. Just have a look. Venous return has become zero. Why? Because the right atrial pressure has become equal to mean systemic filling pressure. TPR is total peripheral resistance. What is the meaning of circulation is stopped by clamping the great vessels? Then pressure everywhere becomes equal, right? What you can see from the figure, more is the RAP is right atrial pressure, right atrial pressure. RAP is right atrial pressure, right? More is the right atrial pressure, less is the venous return, and as you can see the figure is going via a downslope. As the right atrial pressure increases, the venous return is decreasing, and at this point the venous return has become zero, right? Zero. So what happens? This point is mean systemic filling pressure. Interestingly, as you can see, as the right atrial pressure keeps on decreasing, as I'm going from 0 to -4, the venous return keeps on increasing. Yes, MSFP, that's correct, Shaikh. So, but after -4, there is no further increase in venous return. Why? Because the more negative pressure causes collapse of the veins. So, there is no further increase in venous return. Right? So, more negative pressure causes collapse of the veins. So, there is no further increase in pressure. There is clamping of the veins का मतलब है, clamping means that there is no venous return. So more negative pressure, collapse of the veins, so no further increase in venous return, right? That is the meaning. Yes, absolutely correct, Aditya Kundir. Pressure will be same everywhere. Moving on to the blood pressure. Systolic blood pressure. Thank you, Ayushi. Systolic blood pressure is the maximum pressure exerted during systole. Diastolic is the minimum. Remember, pulse pressure is directly proportional to the stroke volume, but inversely proportional to the arterial compliance. Right? So, if the arterial compliance decreases, as in old age, the pulse pressure will increase, right? So arterial compliance decreases in old age due to the effect of aging or atherosclerosis, and the pulse pressure will increase. So in old age, the pulse pressure is more, right? Pulse pressure, you also know that the mean blood pressure is nothing, or mean arterial pressure as it is called. It is diastolic blood pressure plus 1/3 of pulse pressure. Yes, welcome Lakshay. Let's move on to the cardiovascular reflexes. Baroreceptor reflex. Remember, whenever we have increase in mean arterial pressure, how can it happen? Person is in standing posture, person suddenly lies down. As person suddenly lies down, thank you Srinivas, as person suddenly lies down, there is increase in venous return, which causes increase in mean arterial pressure, and which will now further cause so more mean arterial pressure means, if this is the carotid sinus, we can very well say that there would be more stretching of the carotid sinus. More stretching means more firing rate, which is the nerves 9th and 10th nerves, right? But which is the main baroreceptor? Carotid sinus. Yes, negative feedback, absolutely correct. It stimulates the NTS. Yes, NTS is my integration center. Nucleus of Tractus solitarius. Nucleus of Tractus solitarius, right? Once the nucleus of Tractus solitarius is stimulated, this is via the release of neurotransmitter glutamate. Thank you, Shubham. And yes, Huma, thank you. So once the CVLM is caudal ventrolateral medulla, remember it is known as commonly by the name depressor center. This is again stimulated via the release of glutamate. Then CVLM inhibits the RVLM, which is also known as the pressor area. If the RVLM is inhibited, what will happen? Sympathetic stimulation is decreased. Less sympathetic stimulation means less stroke volume, less total peripheral resistance, and less heart rate. Then also NTS stimulates the CIC. What is CIC? That is nucleus ambiguous. Nucleus ambiguous, right? Which is also known as cardiovagal inhibitory center. CVLM Sangeet Joshi is caudal ventrolateral medulla. Nucleus ambiguous is the new name of the cardiovagal inhibitory center. RVLM is rostral ventrolateral medulla. It increases the vagal stimulation, which will again decrease the heart rate, right? So remember, as we study in class as well, what will be normalized first, heart rate or the blood pressure? Heart rate or the blood pressure? Remember, heart rate will be normalized first because it is being governed by two factors, right? Two factors. Nucleus ambiguous is the new name of cardiac vagal inhibitory center, right? Nucleus ambiguous. Moving on to RAS, renin-angiotensin aldosterone system. So stimuli which increase renin are hypovolemia, hemorrhage, hypotension, dehydration. Thank you, Dr. Tanish. And we have the increased sympathetic discharge, prolonged standing. One question for you all. Sympathetic discharge acts via which receptor on the JG cells? Yes, which receptor? Beta 1, beta 2, alpha 1, alpha 2. Remember, the answer is beta 1 receptor on the JG cells. Once the yes, absolutely correct, Sakshi. So we have the renin, which causes conversion of angiotensinogen to angiotensin 1. Then I have the ACE, which is angiotensin converting enzyme. Yes, so can you tell me where is the location of ACE? Where is the ACE located? Angiotensin converting enzyme. Where is ACE located? Yes, quickly give the right answer. Where is ACE located? Yes, anyone? Location of the ACE. Don't say lungs. I want to know where in lungs. No. ACE is not from liver. The location is pulmonary endothelial cells. Pulmonary endothelial cells, right? It is present in the pulmonary endothelial cells or pulmonary endothelial capillaries, right? Pulmonary endothelial capillaries. Naturally, lungs mein hoga. Yes, everyone is correct. And what does angiotensin do? It's a very strong vasoconstrictor. It increases the release of aldosterone from zona glomerulosa. Angiotensin 2 also directly increases the sodium reabsorption in the PCT and thick ascending limb of loop of Henle, right? It increases the sodium reabsorption, and angiotensin 2, that's correct. Angiotensin 2 also, yes, a vasoconstrictor, that's correct. It increases sodium reabsorption in PCT and thick ascending limb. They can ask you this. And remember, angiotensin 2 stimulates the center known as SFO, which is a circumventricular organ, subfornicial organ. Subfornicial organ stimulation causes or stimulates increased thirst. More thirst means more fluid intake. Absolutely correct, Navneet. Very good. Moving on to Mary's law. These are old archaic laws. The Mary's was a scientist who observed, she observed that the heart rate is inverse to blood pressure. Bainbridge is sudden increase in blood volume increases the heart rate, and Bazol-Jarisch is that injection of substances such as, thank you Nitish, yes, S of soap, absolutely correct Rishabh. The serotonin, capsaicin, viratridine and phenyl biguanide, if I inject directly into coronary arteries, I observe both hypotension and bradycardia. Right, that is an observation of Bain and Bridge. Moving on to CNS, the rapidly adapting or the phasic receptors. So we have the Pacinian corpuscles. The main functions of the Pacinian corpus, main functions of the, yes, MI, post MI also I see the, the Bazol-Jarisch or the coronary chemoreflex. So Pacinian corpuscle, main functions, if I ask you, fast vibrations, and also Cushing reflex, Nagaraj Vittal, I have explained in back to basic videos. Please go through it. If you are not able to understand, at the last of the session, I'll give you my WhatsApp number. So Pacinian corpuscle is for fast vibration and deep pressure. Remember, the key word is deep pressure, also known as poking sensation. Poking sensation. Yes, Avani, I'll try. Meissner's corpuscle, remember I told you till 9 we will finish, so you still have time, right? So Meissner's corpuscle is for slow vibrations. The Meissner's is for slow vibration. Texture, topognosis. Yes, absolutely correct, Sheendhar. Fine and well localized touch. Fine and well localized touch. Right? Yes, fast vibration up to 800 Hertz. That's correct. Hair and organs, light movement over the skin. Light movement over the hairy skin. Topognosis is a study of surfaces. Light, fine and well localized touch is also known as discriminative touch. Light movement over a hairy skin. Light movement over hairy skin. Then moving on to the slowly adapting receptors, Merkel disc, remember lots of overlap here. Merkel disc again for texture. Yes, Meissner's is mainly in the glabrous, non-hairy skin. Merkel is more in the hairy skin. Texture, topognosis. Braille, the better answer is Meissner's, as we say, right? Meissner's is the better answer for Braille. For Braille, the better answer is Meissner's. So Merkel disc, texture, topognosis, but I will like you to remember 2-point discrimination is via the Merkel, right? So texture, topognosis, again fine and well localized touch, but the 2-point discrimination is specifically via the, yes, Sheendhar, that's correct. Moving on to Ruffini endings. The Ruffini endings are again for fine and well localized touch. And also for, I'll just show you in a while, Fatima, fine and well localized touch. Yes, 2-point discrimination, minimum in the fingertips, as we say, maximum on the back. Fine and well localized touch, the Ruffini nerve endings, and also for prolonged pressure, also known as sustained pressure. C mechanoreceptors are for crude touch. Crude touch, remember only pressure. Thank you, Maulik. Crude touch, pressure. Muscle spindle is for muscle length. Muscle length, or also sometimes we say passive stretch. Golgi tendon organ is for muscle tension. Also we say forceful or the powerful stretch. Powerful or the forceful stretch. Joint capsule receptors is for proprioception, which you all know is joint and position sense. Proprioception, joint and position sense. Thermoreceptors is for, temperature of the object placed on the skin. Nociceptors is for pain detecting receptors, right? Let's move on to the muscle spindle. So muscle spindle, as we discussed, we have the intrafusal fibers, right? Nuclear bag 2 to 3. Yes, let's revise nuclear bag dynamic, which is the afferent fiber. Now you people can quickly write down the answers. 1A, which is the afferent fiber for nuclear bag static. 1A and 2, which is for nuclear chain static. 1A and 2, right? Then which is the, so sensory afferent, already I have written at the top. Sensory afferent is 1A and 2. And which is the motor efferent? The motor efferent is A gamma dynamic. This is A gamma static, and this is again A gamma static, right? So yes, previous slide, Revati V, please have a look quickly. Moving on to the ascending tract. So posterior columns carry which sensations? Posterior column carries which sensation? Yes, fine touch, conscious proprioception. Conscious proprioception, as right now we are writing, we are aware about our movements. Conscious proprioception, 2-point discrimination, 2-point discrimination, fine touch, conscious proprioception, tactile localization, vibration, very good, absolutely correct. Yes, what else? Stereognosis, very, very important. What is stereognosis? Ability to feel size and shape of the object when held in hand, right? Stereognosis. Then we have graphisthesia also. This is a question which was asked recently. Graphisthesia. What is graphisthesia? Ability to recognize writing on the skin purely by touch. Remember, if I, with your eyes closed, if I write an alphabet A on your palm or the hand, you will be immediately able to tell me, right? So graphisthesia, ability to recognize writing on the skin by touch. Yes, pressure, I am deliberately leaving Dr. Dakshani. I'll just discuss that in a while. Lateral spinothalamic, that is for pain and temperature. Anterior spinothalamic, that is crude touch, tickling, itching, sexual sensations, and remember barognosis. Barognosis is the ability to judge pressure. Barognosis is the ability to judge pressure. Barognosis, ability to judge pressure. But ability to judge various degrees of pressure is via posterior column, right? So that was the important bit here. Ability to detect various degrees of pressure. So pressure is one sensation which has a dual transmission, right? Dual transmission. Spinocerebellar tracts from the lower limb, if I ask you, from the lower limb we have the dorsal spinocerebellar tract and ventral spinocerebellar tract. Yes, unconscious proprioception. Absolutely correct. These all carry the unconscious proprioception for which we are not aware. Wherever I see the word cerebellum, it has to be unconscious, right? Unconscious proprioception. Unconscious proprioception. Moving from the lower to the upper limb. So which are the ones which are from the upper limb, right? Which are the ones from the upper limb? So from the upper limb, we have the cuneo-cerebellar tract and the rostral spinocerebellar tract. Very quickly now, without me writing anything, which two tracts are? Yes, ability to judge or detect various degrees of pressure. That's the same thing, like ability to feel pressure or judge pressure, ability to detect various degrees. That means if I touch you, if I am pressing on something, that is by the anterior spinothalamic, but the ability to judge whether the pressure is more or less, that is will be via the posterior column, dorsal column. So dorsal spinocerebellar tract, let me highlight, and cuneo-cerebellar are ipsilateral. They are uncrossed. And ventral spinocerebellar tract and the rostral, they cross twice, right? They both cross twice. They crosses twice. So naturally, all of them will terminate in, remember dorsal is and cuneo is uncrossed, right? So basically all of them will terminate in ipsilateral cerebellar hemisphere. Yes, crosses twice. Absolutely correct. And all of them will terminate, whether it is any tract, all of them will terminate in ipsilateral cerebellar hemisphere, right? So moving on to the next bit here, which is the tracts. Let's quickly discuss the tracts. So we have the dorsal column medial lemniscal pathway. Remember, the first order neuron is the DRG, dorsal root ganglion. It goes from receptor directly to the medulla. Then there is crossing over of the fibers. The crossing over is known as medullary decussation. We have two groups of nuclei. Thank you, Monisha, Anuj and Deepika. So we have two nuclei. Can you name the nuclei for me in the medulla? It is the nucleus cuneatus and the gracilis. I'll just show you Syed Mohammed. Dekhiye fatafat quickly. Yes, Syed Mohammed, be quick. So then we have, coming to the DRG, decussation of the, yes, gracilis is medial and cuneatus is lateral, right? This is the gracilis and this is cuneatus. Absolutely correct. Cuneatus is from the upper part of the body, gracilis lower. Second order neuron will start from the medulla to the VPL of thalamus. This is ventero-posterior-lateral, and then going to the primary somatosensory cortex, right? Then coming on to the spinothalamic tract, again we have the DRG, right? It synapses in the dorsal horn, the fibers cross over. So the second order neuron is from the spinal cord to the VPL of the thalamus and again terminating in areas 3, 1 and 2. Moving on to sensory homunculus. Remember, the representation of the body parts has nothing to do with the size of your body part. More sensitive areas have higher cortical representation, right? More sensitive areas have higher cortical representation. More sensitive areas have higher cortical representation. So which parts have the maximum representation? We have the face, lips and the tongue. Face, lips, tongue and the hands have highest or more representation. Thank you, Prince. they have face, lips, tongue and hands have the highest representation, and the least representation is of trunk and the back. Least representation is of the trunk, back and the lower limbs, right? The trunk, back and the lower limbs have the least representation. Absolutely correct. Yes, everyone is right here. Sensory homunculus, as you all know, post central gyrus. Yes, motor homunculus, Namrata, abhi I'll tell you, don't worry. I'll discuss that as well. Areas number 3, 1 and 2, right? Post central gyrus. Yes, genitals are also included in the list. This is a wonderful figure showing, thank you Diya, this is a wonderful figure showing the arrangement of the fibers. Just remember this simple mnemonic here, that the arrangement of the fibers in tracts of Gall and Burdak. Burdak is the term used for cuneatus. Burdex is the term used for cuneatus. Gall is the term used for gracilis, right? Now, arrangement of the fibers in the spinothalamic tract, anterior and lateral, is, just remember this easy way to recall this. Lowermost fibers, thank you Sanjana, lowermost fibers are the lateralmost. Lowermost fibers are the lateralmost in the lateral spinothalamic tract. LLL. Very good, Navneet. Absolutely correct. Yes, definitely, Samriddhi. You will be getting the PDF. Don't worry. LLL. That is the way I remember this. Lowermost fiber are lateralmost in the lateral spinothalamic tract. So, यहाँ पे in the spinothalamic, the sacral is at the lateralmost. In the posterior column, the sacral is in the medialmost. Divya Tripathi, please don't do this, right? Just attend the class. Yes, don't do that. So, descending tracts, right? Yes, please pay attention. Don't do this. So, descending tracts, motor, you can wish at the end once the class is over, right? And directly DM her, right? Please don't do this. So, medial descending tracts, they basically are going to stimulate the axial muscles and they help in maintenance of tone and posture. The medial descending tracts are vestibulospinal tract. Thank you, Vanathi. Vestibulospinal tract, anterior corticospinal tract, and tectospinal tract. So what happens? I also wish her birthday from my side, but please don't do this here, right? So what happens here is vestibulospinal tract, anterior corticospinal tract, and tectospinal tract, they all stimulate A alpha motor neurons of the lower limb extensors. 5L nahi hai, it is only 3Ls. What I was saying, lowermost fibers are the lateralmost. That means the sacral fibers are at the lateralmost. The cervical fibers are medialmost in the lateral spinothalamic tract, right? But in posterior columns, the lowermost fiber, the sacral fibers are medialmost. Moving on to A alpha of the lower limb extensors, then we have the pontine and the medullary reticulospinal tract. We have the pontine reticulospinal tract and we have the medullary reticulospinal tract. Pontine reticulospinal tract stimulates the A gamma motor neurons and the medullary inhibits A gamma motor neurons. Both are stimulating or inhibiting again the lower limb extensors, right? Then moving on to the lateral descending tracts, the lateral descending, we have the corticospinal tract. Mera birthday nahi hai, Tarun Kumar, it is not my birthday, right? So, it is the lateral corticospinal tract. Anushka, basis of decorticate posturing I have taught in B2B video. Please go through it. Lateral corticospinal tract and rubrospinal tract. Remember, it originates from the red nucleus. And both of it stimulate A alpha motor neurons, mainly of the upper limb flexors, right? Mainly of the upper limb flexors. Chale, let's move on to corticospinal tract. Motor homunculus, somebody was asking me. Let's find out. So corticospinal tract fibers originate from multiple areas. Area 4, 6 and 8, 3, 1 and 2. Passes through the internal capsule, crossover in the medulla. You already know this is known as which decussation? This is now pyramidal decussation, right? 80 to 90% of the fibers cross, which constitute the lateral corticospinal tract. Upper limb flexors, Shreya, upper limb flexors, mainly of the A alpha motor neurons of the upper limb flexors. Right, pyramidal decussation, anterior corticospinal tract is the one which descends downwards. Motor homunculus, yes, motor, thank you RN Yadav, that's right. Motor homunculus representation of the various, this is now in the precentral gyrus. Devi Gangotri, for the decorticate and decerebrate, you will have to go through the back to basic videos. So precentral gyrus. Motor homunculus, precentral gyrus, area 4, primary motor area, as you know. Yes, red nucleus is fine motor action. Absolutely correct. So motor homunculus, area 4, and again we say here the more complicated movements. Welcome Hakim. So more complicated movements. The more complicated movements have higher representation. So any part which is involved in more complicated movement have higher representation, right? More complicated movements have higher representation. So which are the common muscles of, yes, a lot of people are writing the right answer in the chat box. I cannot see that. So muscles of vocalization. 60 नहीं है नीरज, 80 to 90 है, 80 to 90. Vocalization, salivation, and that is 10 to 20. 80 to 90 है, and anterior corticospinal is the remaining 10 to 20. Vocalization, salivation, mastication. These have highest representation. Thank you, Soham. This is the highest representation. And yes, even the hands and fingers, that's correct. So vocalization, salivation, mastication, hands and the fingers, high representation. Again, the least representation is again of trunk and back. I am talking about muscles, Shashank, muscles. Let me add muscles of vocalization, salivation and mastication. Shashank, muscles, right? Muscles. Moving on to the two reflexes here, and I've added one more actually. So stretch reflex. Let's quickly revise. So what is the receptor? Okay, thank you. So what is Arshpreet? That is correct. What is the receptor for the stretch reflex? RST is reticulospinal, muscle spindle, which are the afferent fibers 1A and 2, right? And which is the center, as you can see, ventral horn of the spinal cord, which is the efferent A alpha motor neurons. What is the response? Contraction of the muscle contraction. What is the stimulus? I think I mentioned it but did not write it. Muscle length, change in muscle length, right? Change in muscle length or passive stretch. change in muscle length or passive stretch. What is the response? Contraction of the muscle contraction. Over here in this knee jerk reflex, it will cause the extension of the leg. How many synapses can you see? Naturally, you will tell me you can see how many synapses? Only one synapse. So number of synapses 1. It's a monosynaptic reflex. Absolutely correct. Most of you, that's correct. Monosynaptic reflex. Let's move to inverse stretch reflex. Remember, the stimulus for the inverse stretch reflex is powerful stretch. Powerful stretch or increase in muscle tension. Receptor is Golgi tendon organ. Stimulus will be change in muscle length. Anu, likha hai, change in muscle length or the passive stretch, right? That is as you are hitting with a hammer onto the knee patella, right? So receptor is Golgi tendon organ, GTO, Golgi tendon organ. Afferent is 1B. This has been asked many times in the exam. Now please understand, here there are two synapses, 1 and the 2. And this one is actually the center will remain the same, ventral horn. And what happens here? This is an inhibitory interneuron. This is an inhibitory interneuron. Yes, absolutely correct. We are trying to pick up a more load than we actually can. Inhibitory interneuron releases glycine, inhibits this efferent, which is A alpha. Response is relaxation of the muscle. Why is the muscle relaxing? To prevent the rupture of the tendon. How many synapses? Bisynaptic, 2 synapses. Muscle tension है, यहाँ पे length नहीं है. Nagaraj, it is muscle tension for the Golgi tendon organ or powerful stretch. Muscle length is for the muscle stretch reflex or the normal monosynaptic reflex, right? Prevents the rupture. Absolutely correct. Bisynaptic. That is the right answer. Moving on to flexor withdrawal reflex. Please have a look at this one. This is known as flex. No, Shreya, this is not Ranshaw. This is not Ranshaw inhibitory interneuron. Flexor withdrawal reflex, very interesting. Just have a look at this beautiful picture. So what is happening? We have the nociceptors, which are known as the pain detecting receptors. Yes, Tanish, I'll do that. Thank you. Flexor reflex afferents are type 3 and type 4 fibers. We do that in Lloyd and Hunt. Then as you see, the 3rd and 4 fibers enter via the dorsal horn. Now what will happen? The flexor withdrawal reflex is commonly triggered. Let's say these are my 2 lower limbs. I'm walking like this. Suddenly this limb lands up on a pointed object. What will I do? I will do flexion of the limb to remove the limb away from the painful stimulus. But I will do extension of the other limb to maintain the postural balance, right? So what is happening here? Let's have a look at the ipsilateral. This is the ipsilateral limb. This is the contralateral limb. So in the ipsilateral limb, I stimulate the flexor muscle, so it contracts. And the extensor muscle will inhibit. But in the contralateral limb, this is the ipsilateral limb, this is the contralateral limb. In the contralateral limb, the flexor neuron is inhibited and the extensor is stimulated, right? So ipsilateral limb will show flexion, contralateral will show extension. So in the ipsilateral limb, we are seeing flexion. In the contralateral limb, we are, thank you Yukta, we will see extension. FRA is flexor reflex afferents. FRA stands for flexor reflex afferents. I'm writing over here. Flexor reflex afferents. This can be seen in upper limb also, Paras Kapoor, but there I will not require extension of the contralateral limb. So mainly it is being mentioned for the lower limbs here. But Paras has asked a good question. It can also be seen in upper limb. Suppose you accidentally touch something hot on the gas. Then what will happen? You will only flex your upper limb. There is no need for extension of the opposite limb. No. This is not bisynaptic, Shreya. There are many synapses. Considering number 1, number 2, 3, 4, 5, 6, 7, 8 and 9. So there are so many synapses, right? It is much more than bisynaptic. Moving on to cerebellum. So it's a polysynaptic reflex. Absolutely correct. It is having almost 7 to 8 synapses, right? It's a polysynaptic. Cerebellum, as we say, we remember it like this. It has 3 parts. Let's look at 3 parts: spinocerebellum, cerebrocerebellum and vestibulocerebellum. So spinocerebellum, vermis and the paravermis. Shreya Pandey, we will be finishing in half an hour, right? So no need to take break. So vestibulocerebellum, what is the function of the vestibulocerebellum? The vestibulocerebellum function is balance and the eye movements. No, Sakshi, it will also be seen in upper limb, but in upper limb there is no requirement of extension of the contralateral limb. So only flexion will occur. 3 parts, 4 pairs of nuclei, 5 types of cells. Absolutely correct. Balance and the eye movements. Which is the deep nucleus? The deep nucleus is vestibular nuclei. Vestibular nuclei, right? Medial part, medial lobe. Yes, what is the function of the medial lobe? Function of the medial lobe in both the cases, vermis and paravermis, is motor coordination. Coordination of the movements in motor performance. Motor coordination, right? In the vermis, I have which nucleus? Yes, quickly let's revise. We have dentate, interpositus, vestigial, interpositus and dentate, right? So basically remember, in the vermis, the nucleus associated with vermis is vestigial. The nucleus associated with, yes, DFG, absolutely correct. Don't eat greasy food. Paravermis is emboliform. There is a reason I am not using fine pen. I'll tell you. The reason is that lot of students say that they have difficulty in reading from the PDF, right? That was the reason. Otherwise, you must be thinking why you have to tell me so many times, right? So emboliform plus globose, that includes nucleus interpositus. Cerebrocerebellum function is planning and programming of the movements. Planning and programming. Yes, don't eat greasy food. DEGF or doctors eat good food. Planning and programming of the movements. The deep nucleus associated is dentate nucleus, right? Dentate. Then moving on to the cells of cerebellum, which is the only cell which is excitatory here? Yes, granule cell is the only excitatory cell, right? Remember that. Granule is only excitatory cell. These all are inhibitory cell, which is the cell which only gives the output to the deep cerebellar nuclei as shown in the figure. Please have a look now. These are the Purkinje cell shown here. These are the dendrites. These are cell bodies. Purkinje cell output of the cerebellar cortex is from the Purkinje, and of the cerebellum is from the deep nuclei, right? The input is via climbing and the mossy fibers. Remember, climbing fibers enter through, yes, anyone, which peduncle or which nucleus? Inferior olivary. Lateral part is, I already mentioned, planning and programming. Harshal, planning and programming. Yes, inferior olivary nucleus, right? Purkinje cell, this is the figure shown. Purkinje cells project to, this is a previous question. The Purkinje cells project to deep nuclei. Only excitatory cell, right? Inferior olivary nucleus, absolutely correct. Let's move to basal ganglia. The basal ganglia, caudate plus putamen in physiology is known as striatum, right? Caudate plus putamen in physiology is known as striatum, right? And cerebellum, remember Sankit, Manoj, Vora, it is the about the vermis will receive input from the axial muscles, the paravermis will receive from distal muscles, project to deep cerebellar nuclei, that is striatum. 95% of the neurons of the striatum release GABA. Internal segment, again GABA. External segment, mainly GABA. Pars compacta, dopamine. Pars reticularis, GABA. Subthalamic nucleus, only excitatory structure, only excitatory structure. Aditya, just have a little patience, we'll be able to finish till 9, 9, 10, right? Glutamate. Neostriatum is same as striatum structura, but corpus striatum includes globus pallidus as well. Neostriatum is same as striatum. Moving on to skeletomotor circuit of the basal ganglia. So what we can see is a wonderful picture which is showing, just a revision quickly now. We have a direct pathway which facilitates the movement. We have the indirect pathway which inhibits the movement. The green is stimulatory, the red is inhibitory. So from the motor cortex, the information comes to striatum. Paravermis predna from the distal limbs. From the direct pathway, it goes to globus pallidus internus, thalamus, and direct is excitatory. So I'll just write in short, you can refer to the back to basic. Dopamine via D1 facilitates the direct pathway. Dopamine via neocerebellum is same as cerebrocerebellum. Yes, direct dopamine via D1 stimulates the direct pathway. Output of the direct is stimulatory. Dopamine via D2 inhibits the indirect pathway. Indirect is inhibitory. So I am inhibiting the inhibition, but I am stimulating the stimulation. So all the eyes are together, right? And the net output in normal people is always stimulatory. Net output is stimulatory. Let's move to hypothalamus. So hypothalamus, which is the hunger, thirst, rage and aggression center. Yes, what is the answer? Ventromedial or lateral? Quickly, ventromedial or lateral? Ventrolateral hypothalamus, right? Ventrolateral. Yes, thank you very much. Satiety and reward. Ventromedial, right? Ventromedial. Then heat gain center. Posterior or anterior hypothalamus? Quickly, posterior or anterior? Heat gain. Heat gain is posterior. Heat loss is anterior. Remember the mnemonic AC. Anterior including the preoptic nuclei. Anterior including the preoptic nuclei, right? Remember the mnemonic, whenever you are in hot weather, you will switch on the AC. Anterior cools you down. Circadian rhythm, suprachiasmatic nuclei, right? Suprachiasmatic. Sexual activity, anterior most and posterior most portions of the hypothalamus. Neurosecretion, we have the supraoptic nuclei, and we have the paraventricular, right? So supraoptic main is ADH, paraventricular main one is oxytocin. How do I remember this? Remember, we have a SAD pox. Very good, Sachin Kumar. That's the perfect answer. Supraoptic ADH, paraventricular oxytocin. Fever. What is happening here? So just have a look quickly at point 1. At point 1, either due to release of interleukin 1, there is a set point rises suddenly to high value. So point 1 is rising of the set point. The set point rises. What is point 2? Now the body will generate the heat generating mechanisms to match the set point. So tell me, at point 2, anterior hypothalamus will be stimulated or posterior? Quickly. Set point is raised to a high value. Remember, the body temperature will rise. AC is anterior cools you down. Anterior cools you down. This is now activation of posterior hypothalamus, heat gain center. Activation of posterior hypothalamus, shivering. Absolutely correct. Then, crisis. Crisis can happen during the natural course of the disease, or maybe you have taken an antipyretic. So natural course, or maybe you took an antipyretic, paracetamol. What will happen? Lowering of the set point, point number 3. Immediately, which center I will activate in point 4? Now I will stimulate anterior hypothalamus. And anterior hypothalamus is my heat loss center, right? Sweating. And the body temperature again comes back to normal, right? So let's move on to respiratory system. So in respiratory system, we have the spirometry. So we all know IRV, inspiratory reserve volume, inspiratory capacity, tidal volume, ERV, RV, which volumes I cannot measure. Crisis means when the fever is coming down. Which volumes cannot be measured by a spirometer? I cannot measure RV. I cannot measure RV plus ERV, which is functional residual capacity, and I cannot measure vital capacity plus RV, which is total lung capacity, right? So I cannot measure anything which has RV. Which is the best way to measure the functional residual capacity? Quickly tell me the name of the best method to measure FRC. Yes, the best method is whole body plethysmography. Whole body plethysmography, right? It is the most accurate method. Most accurate. Apart from this, we have helium dilution and nitrogen washout also, as everybody has pointed out. Let's move on to flow volume loop. Very quickly, let's have a look at obstructive versus restrictive. In obstructive lung disease, COPD, asthma, what we observe, the TLC increases because there is obstruction to the airflow. Then the residual volume increases. FVC is either normal to decreased, but FEV1 upon FVC is always decreased. Restrictive lung disease, problem in the lung expansion, volumes are affected more than rates, everything is decreased. The ratio is either normal or decreased, right? Peak expiratory flow rate and mid maximal expiratory flow rate are less affected. Point 4 was that the body temperature will you reduce. Why? Because of the activation of heat loss centers. Moving on to flow volume loop, remember, as I am moving from 0 to 8, my volume is increasing. That means in a normal person, this is total lung capacity and this is residual volume. Now very easy for you to tell me which is obstructive and which is restrictive. A is obstructive. Why? Because in obstructive, as you can see, the total lung capacity is increased, residual volume is also increased. In the B, the total lung capacity is decreased, residual volume is also decreased, right? So basically this is obstructive lung disease curve. The A1 is known as scooped out curve or the coved curve, scooped out curve or the coved curve. It is like a cave, right? And restrictive lung disease, which is shown here, is due to the more common we say parenchymal lung disorder. In the parenchymal lung disorders, R for restrictive lung disease, R the loop shifts to the right. Right? Yes, thank you so much. So let's move on to the, sometimes you can have a large airway obstruction. Now large airway obstruction, remember, large airway obstruction will give you a stridor. Small airway obstruction gives a wheeze. It is very difficult to distinguish the two. So we go for the flow volume loops, right? If I have a fixed obstruction, which can occur in tumors, please refer for further discussion to my back to basic notes, right? So large airway obstruction, tumors, foreign body, both expiration and inspiration are affected. Remember, this one is expiration, this one is inspiration. So this is known as box type of curve. The extrathoracic variable, the key word to remember is this can happen due to vocal cord paralysis. 20 minutes more. Vocal cord paralysis. Intrathoracic variable, yes, large stridor. Intrathoracic, very few examples. Intrathoracic extension of a large goiter. The way to remember is extrathoracic, the expiration is normal. Intrathoracic, inspiration is normal, right? So here inspiration is nearly normal, here expiration is almost normal, right? Let's move on to the airway resistance. Where is the airway resistance maximum? Please remember the answer is medium sized bronchus. In the medium sized airways, the airway resistance is maximum. Moving on to the oxygen content, I can find out the oxygen content. Yes, tracheal stenosis, Mehak, is an example of foreign body, or it's an example of extrathoracic fixed obstruction. That is why I did not write it. It is not an example of intrathoracic. Oxygen content, hemoglobin 1.34 is oxygen carrying capacity, percentage of saturation. PO2 is the partial pressure of oxygen dissolved. 0.003 is the solubility of oxygen. Oxygen hemoglobin dissociation curve, let's quickly do that. So we have a P50, normal value of P50, yes, most of you know that, 26 millimeter of mercury, right? Ishan Singh, VQ graph, please go through the notes, right? So right shift can happen, increase in PCO2, increase in hydrogen ion, decrease in pH, increase in temperature, increase in 2,3 DPG. What are the mnemonic where the 2,3 DPG increases? Remember the girl with the name Geeta. GET triple A, Geeta. What is Geeta? Growth hormone, exercise, thyroid hormone, anemia, growth hormone, exercise, thyroid hormone, anemia, androgens, and high altitude. Androgens and high altitude. In all these conditions, 2,3 dpg increases, right? What are the conditions for left shift? Remember, apart from less PCO2, less hydrogen ion, the important one is the decrease in 2,3 dpg, hemoglobin F, myoglobin. I am adding two more here, which is very, very important. Fetal hemoglobin, and that is written over here, sorry, bank blood. The blood which is stored in blood bank blood, and carbon monoxide poisoning. Now one question for you all. I'm making some graphs here. You will have to tell me the first one. This is like this. This is Y. This is X. The green one is X. And we have a third one, which is Z. So out of X, Y and Z, remember X is for extreme left shift. Myoglobin, very good. Rectangular hyperbola. Let me see all of you who have given the right answers. Rectangular hyperbola. Y could be my fetal hemoglobin, or it could be bank blood. And carbon monoxide poisoning is Z, because remember, saturation is decreased. Right? Let's move on now to the GI tract. So we are almost able to finish within next 10-15 minutes, right? Which are the pacemaker cells of the GIT? Interstitial cells of Cajal. The BR is the rhythmic variation of the amplitude of smooth muscle of the recording of the electrical activity of the smooth muscle of the GI. Frequency and amplitude both are variable, maximum in the duodenum, minimum in the cecum, right? What you can see from the figure, as this is number 3 spike potential, only 1 3. More is the frequency of the spike potential, more is the height of contraction, right? More is the height of contraction. Please see the previous figure quickly. So percentage saturation is decreased. Z is the carbon monoxide poisoning. Saturation is decreased. That is the reason. Yes, I think already I've given you time. You can see from the recording later on. And now, have a look at this figure. As soon as I give acetylcholine, the frequency of the spike potential increases, and I can see that the height of contraction also increases. Neural regulation, Shubham, please go through back to basic notes. Samajh nahi aayega to you can get in touch with me on my WhatsApp number. I'll give you later on. Epinephrine, if I give sympathetic stimulation, the frequency of the spike potential decreases. Right? So height of contraction starts to decrease. As soon as you give epinephrine, as you give the vagal stimulation, the height of contraction starts to increase. Right? Let's move on to cellular mechanism of the absorption of carbs. So carbohydrates are mainly absorbed in jejunum, although seen in both duodenum and jejunum, but mainly in jejunum. So which is the major one? Remember, for glucose it is SGLT1 and GLUT2. For glucose it is SGLT1, and this should be, this one is GLUT2, right? And for fructose it is GLUT5. So F for fructose, F for facilitated diffusion. And this is naturally secondary active transport, right? Let's move on to the next one, proteins. Remember, for amino acid, I require amino acid. Sodium for amino acids. For di and tripeptides, I require hydrogen ion, which is the name of this transporter, pepT1, which stands for peptidyl transporter 1 or peptide transporter 1. Second degree is secondary, absolutely correct. This is also secondary active transport. This is also secondary, right? Second degree, that is secondary active. Then amino acid transporters will further push the amino acids into the blood vessel. For fats, we combine the fatty acids and cholesterol, we combine them with the apoproteins to form the chylomicrons, and then the chylomicrons move into the lymph via the thoracic duct, then into the blood vessels, and finally into the liver, right? Moving on to the movements of the GI tract, we have the segmentation contraction, which are, remember, the mixing contractions, where these pockets are formed in both small and large intestine, which move the chyme to and fro, right? They move the chyme to and fro. So as the chyme moves to and fro, there is increase in absorption of the GI nutrients, right? These are known as mixing contraction. Peristalsis is the forward propulsive movement of the food, and migratory motor complexes are the ones which are seen in fasting state. Let's move on to the peristalsis. It's a forward propulsive movement of the food as the bolus stretches the intestine. Remember, the neurotransmitters which are released anterograde to the bolus are the NO and VIP. VIP is considered as the main one here, and substance P and acetylcholine will cause contraction. The bolus moves forward at the rate of 2 to 25, right? 2 to 25 centimeter per second. Immediately as the bolus stretches the intestine, remember, it causes the increased release of serotonin, which basically will cause the stimulation of myenteric plexus. Migratory motor complexes, now everything is written on the figure again. It occurs in the fasting state, starts as a ring of contraction from the body of stomach till the distal ileum. Remember, they have a clearing action. And also remember that first MMC can occur after up to 120 minutes, but each subsequent MMC occurs at an interval of 90 minutes. The rate is a typo error here, please correct. This is 5 centimeter per minute, not 2 centimeter. This is 5 centimeter per minute, 5. Right, this is a typo error, right? This is 5 centimeter per minute. Phase 1 is the quiescent phase, where no, or also known as silent phase. Phase 1 is the quiescent phase, right? Almost 80 minutes in duration. Phase 2 and 3 are, 2 is 6 to 7, 3 is 3 to 4, right? In phase 2 and 3, phase 2 we have irregular contractions. Phase 3 we have regular contractions. This is 6 to 7 minutes. This is 3 to 4 minutes. Please remember that together phases 2 and 3 are known as the housekeepers of the GIT. Housekeepers of the GIT, right? So MMCs are hormonally regulated. Can you write down the name of the hormone by which it is regulated? They are hormonally regulated. They are under the control of the hormone motilin, right? Motilin. Let's move on to GI reflexes. Receptive relaxation of the stomach, remember, associated with swallowing reflex. These are vaguely mediated. What happens in receptive relaxation? Fundus and the upper body of the stomach relaxes to accommodate the food with little increase in pressure. Gastrocolic, defecation occurring immediately after having meals, very commonly seen in infants. Very commonly seen in infants who defecate after having meals, right? Gastrocolic Distension of the stomach causes relaxation of the ileus, causes the reflex contraction of the colon. Defecation occurs after having meals, right? Moving on to gastroileal. So distension of the stomach causes relaxation of ileocecal valve. Enterogastric reflex. Enterogastric reflex stimuli is duodenum distension, type of food, acidity. Remember, what is the response? Delay in gastric emptying. Yes, ileocecal valve will respond, will relax. Absolutely correct. This delays the gastric emptying. So basically the stimuli are the duodenal distension, type of food. Remember, fats cause maximum delay in gastric emptying, followed by proteins, and the last by carbohydrates. So fats, proteins and carbohydrates. Maximum delay in gastric emptying is by fats, right? Which are the hormones involved? Peptide YY, CCK and secretin. Moving on to the vomiting reflex, it can be triggered by motion, vertigo. This should be again typo error, vomiting. So this is by the labyrinth cerebellum through the vestibulocochlear nerve, as you know, pharyngeal stimulation via the 9th and 10th nerve, gastric mucosa, and hormones are peptide YY, CCK and secretin, Neeraj. So then we have receptors on the brainstem vomiting center. Now somebody was asking me earlier, area postrema located in the floor of the fourth ventricle is the chemoreceptor trigger zone. CTZ, 5-HT3 and D2 receptors are present on the brainstem vomiting center, which induces a programmed vomiting response. What do I observed in a programmed vomiting response? This question came in November inicet. We have an antiperistalsis which empties the material from the upper small intestine into the stomach. Then the vomiting act proceeds. The patient takes a deep breath, raising of hyoid and larynx to pull the upper esophageal sphincter open. I will close the glottis to prevent the vomiters to going into the trachea, and lifting of the soft palate, followed by contraction of the diaphragm, and finally relaxation of the esophageal sphincter will expel the vomiters. Endocrine system, moving on to the last page now. Hormones which do not need second messenger. This question came last year in the this year in the May exam. So insulin receptor, why does the insulin does not need any second messenger? Insulin receptor itself has tyrosine kinase activity. Then growth hormone, IGF-1, prolactin, and I will like you to add one more, leptin. They act through JAK-STAT mechanism, Janus activated kinases and signal transducers of phosphorylation. JAK-STAT mediated. Hormones using cyclic AMP as second messenger. Remember the ADH that is asked, glucagon and beta adrenergic receptors. These are all previous question. Hormones using cyclic GMP, atrial natriuretic peptide, brain natriuretic peptide and nitric oxide. Hormones using phospholipase, they can ask you ADH, and remember alpha receptors. Finally, the receptors for the lipid soluble hormones. The nuclear receptors are thyroid, estrogen and vitamin A. The D glucocorticoids, aldosterone, testosterone, progesterone and vitamin D is in the cytoplasmic, right? So now I'm sharing my number with you all. So first of all, best wishes from my side. So best of luck. Always keep smiling, right? And I'm signing off. Dr. Kamal Jindal is my name, and I'm sharing my WhatsApp number. Any query you can send me, right? 9711387070. 9711387070. This is my direct WhatsApp number. You can send me any query on my WhatsApp number, right? This is my WhatsApp number, right? So welcome all. Best of luck for the upcoming exam. God bless you all. Take care, right?